Well, hi. I'm Ray Jones, and I'm going to start in a minute. I'll give chance for some other people just to log on a second. One point I will make is that the chat room is going to be quite crowded today. Later on, I shall tell you how to change rooms. We've got 3 rooms there for the breakout discussion, and I'll give you those instructions in a minute. I will make the point that when we do get into discussion, because there's quite a few people there, make sure that you preface your remarks by, in response to what Alan said or what Lawrence has said, or I agree or disagree with someone's name. Otherwise, the chat may get a bit disjointed. But we will also be dividing up into 3 groups. I'm just going to get my PowerPoint back to the right place. And then in a minute we will start. Hopefully you can all hear me. If you have problems with sound, don't please try and put too much in or anything else to do with the presentation. Try and have that solve your problems outside of the chat room, perhaps with Innocencio Maramba, whose email that you will see there. You can always email Innocencio offline, Cito, as he is in the chat room. I think it's now 3 o'clock. I'm going to start. Do health kiosks have a role in 2008? So as I said, my name's Ray Jones. I'm from the University of Plymouth, where I'm Professor of Health Informatics. Before that I was at University of Glasgow. I'm the Master of Ceremonies today, so I'm going to give you my views on health kiosks, but then hopefully we'll hear a lot more from you, because there are a lot of people there in the chat room I know who've had extensive experience of the use of kiosks in various ways and in various modes. So this isn't just about sort of my views, it's everybody's views. So what are we going to talk about? First of all, that's the technical problems. If you have any problems, contact Innocencio, Cito Maramba, and try and keep the chat room for discussion. In case you haven't worked it out, you've got the user list there on the right hand side, you've got the webcast window, and down the bottom you've got the input area for your chat. And please do feel free to type questions or comments as I go through. Obviously I can't answer them when I'm looking at you here in the video window, and I will review the chat room dialogue at the end of the presentation and then respond by this video window. Some people may find too much going on in the chat room a bit distracting from the video window, so perhaps keep it to a minimum. But if you want to type a question now or during the process of my presentation, please do so, and I'll come back to it at the end. Currently you're in main chat room. If you look just above my head there, you'll see a thing saying you are in main. Later on we're going to be able to go to another room, room R1 or R2, and you can do that by typing /room space R1. Make sure that you don't have a space between the slash and the room. You do have a space between the room and the R1, and then press enter, and that will take you off to another room. If you want to come back to room main, you type /room main, back to room R2 /room space R2, and so on. So you'll be able to move between the 3 different rooms, main, R1 and R2, as the proceedings of the discussion go on. And later on we're going to divide the comments between the points of clarification to me, or if you can't decide quite where else to put it in main, and we're going to put discussion about opportunistic kiosks in room R1 and discussion about integrated kiosks in room R2, and I'll describe what I mean by those 2 definitions, opportunistic and integrated, a bit later on. But we're going to try and separate the discussion a little bit to make it a bit more manageable. I'm taking a very broad view of the idea of kiosk. Basically I'm talking about any publicly available touchscreen patient-computer interaction. The Dalek thing on the left there isn't actually a health computer, it's a police touchscreen kiosk in Glasgow. The others are more traditional looking Dalek type computer, one from Wellpoint with a blood pressure monitor, and on the right hand side you'll see a booth being used in a library, and down below it the man on the wheelchair using different types of interaction altogether. So in in a museum display. So clearly computers can be used for a whole variety of things, such as registration to a clinic or welcoming to the clinic. The left-hand picture there is from some health centre in Texas. The bottom right-hand picture is from Camberwell Sexual Health Centre, I've taken from the web. Computers can be used, touchscreens can be used for patient interviewing. As I said, Alan Wenner is in the chat room there, and he says that electronic medical record system providers now include interviewing software part of the software. So over 50 of the EMR providers in the States include patient interviewing, and John Backman, who's from the Mayo Clinic, certainly uses that system, and they have several in their waiting room. So it's not just about information giving, it's also about information interviewing. Or, as in the case here, this is a report from the Picker Institute, and it's looking at patient feedback. So here you've got the computer on a stick idea, where you might get feedback at the end of a session to try and find out about outcomes. As I said, this is an example of a booth where the person's sitting down to use it, and these basic simple ideas about whether someone's standing or whether they're sitting down or where it's sited are actually very important in getting the computer to be used in the way that you want it to be used. That particular picture's from a study we did in Glasgow. This is, as I said, the self-assessment idea, where you can get your weight, height and so on, and I'm sure that many of you will have seen this type of application of a kiosk. And of course increasingly we'll get teleconsultations. This is from the Guardian, from a system installed in Aberdeen. I'm not sure if we have anybody from north of the border logged in today, but this is from the Scottish Centre for Telehealth, and another type of kiosk. So when I've been talking about opportunistic health kiosks, really what I mean are the sorts of things where you're plonking a computer in perhaps in a community setting somewhere. The top left picture there is a HealthPoint computer in a Maryhill shopping centre in Glasgow back in 1991-92, and various other kiosks you see. In Touch with Health on the right hand side there, and the bottom right hand one is Start Here system. Various opportunistic kiosks. And one of the interesting things that I've done for this presentation is I've been looking at the literature, partly for NHS Choices asked me to do a rapid review of the literature, and it's quite interesting to see that kiosks aren't dead. Despite the rise of the internet, there are a lot of papers coming out where kiosks are being, or touch screens are being mentioned. 11 in 2007, 14 2006, 9, 10. So certainly the interest in kiosks and touchscreens is not dying, and it's as much in the USA. 24 of those papers were from the USA, 14 were in the UK, 3 were from elsewhere, and it seems to be divided fairly evenly between where the systems where the main emphasis is on interviewing versus those where they're on information giving or perhaps on consulting. So let's just look at a few examples of publications to give you a flavour of that. If at some point soon I hope to tidy up the report I did and perhaps make it available more publicly with all the references and examples of publications I've got. At the moment I'm just going to give you a few tasters of those. So I don't know if Mark Benaroya is actually in the chat room today. He said he might be able to get in, but he's been looking at the use of patient interviewing using a tablet in an emergency department in Ontario. Another example, this is actually a newspaper article rather than a proper peer-reviewed paper on teleconsultation in Aberdeen. Another example of a publication from down this part of the world, the Royal Cornwall Hospital in Truro, comparing questionnaires with paper and pencil, and they found that what Alan Wenner and others will tell you they found in numerous times is that touchscreens can be used by people of any age, and they found that even the oldest patients, the accuracy was higher with the computer than for paper versions of the scoring system they were looking at. Here's another example from Queensland. Many of you will know about Health Chips system, CHIPS. I can't remember what it stands for now, but it was an information giving system in Australia. That's now been stopped, but it has been in a way. This is son of Chips, looking at particular groups. So Ernest Hunter and others in Queensland recently published a paper on the use of kiosks by indigenous communities in remote and challenging environments. I probably don't have anybody from Australia in the chat room today. It's a bit unsocial hours for them. But this system could be maintained by working with local communities and health providers, and it gave benefits to the community just through involvement in developing the kiosk itself. And there's some evidence from this paper that there was evidence of health improvement from the use of the kiosk. This next paper, which is by Norman et al., is actually a review of a whole number of interventions around physical activity, dietary behaviours, and which are either RCTs or quasi-experimental designs. They looked at 49 publications from 2000 to 2005. They weren't necessarily touchscreen kiosks, but they were computers of some sort being used by patients of some sort. And they found that the e-health intervention, the computer, was superior to the comparison group in 21 of the 47 studies. 24 indeterminate result, and 4 the control group was superior. And they concluded that the interventions needed to be refined, and it perhaps needed more rigorous evaluation, which of course is the fairly standard conclusion of most systematic reviews. But I think there's a fair bit of evidence there that this approach is worth pursuing. Now, why use kiosks? What's the whole point of kiosks? A lot of people say that it's all about equity of access to the internet, and that we have kiosks because not everybody has the internet. Certainly, it is the case that access to the internet can well be overstated. I'm not sure how well you'll be able to see this graph, but if you can see it, the top line shows access to the internet in the UK over time between July 2000 and January 2006, and the top line there is the 16 to 24 year old age group, which is when nearly about 90% or so of that age group have access to the internet in the last year. But the bottom line is those people 65 plus, which is only about 20%. So internet access is still there's still a big age gradient. There are also other gradients by social class, income, by rurality and urban areas, but age is probably the main divider. So one of the things to look at in kiosk use is think about, well, if we're designing the use of a kiosk, let's make it suitable for those people who don't have access to the internet. But let's think a bit more about equity of access to the internet. The internet is used mainly by people searching for information. By definition, you turn the internet on and you're looking for something. It may be that you are browsing around in general, but you're having to put words into Google or whatever else to find information. Another thing is that maybe the internet can be provided, doesn't provide just health information, it provides a whole range of things, and therefore issues about equity of access to the internet isn't not necessarily something which has to be solved by health services. It's something which should be addressed by government or economic means in general. And in Scotland, for example, they installed 1,500 computers in different venues between 2002 and 2004, and some study showed that they seem to have some success, relatively modest success, but some success in making the internet available to those who didn't otherwise have access. I mean, our main concern really is in terms of the accessibility of health information. If we're looking at the provision of health information, leaving aside patient interviewing for a minute, but looking at the accessibility of health information. And that accessibility really has 3 components. The physical availability, have they got access to a computer, either publicly or through somebody socially, through somebody in the family, or maybe at home or at work. do people have the actual money, time, skill, knowledge, mobility, and understanding, perhaps emotional strength to retrieve information? And accessibility can be improved, is a combination of those two things, and can be improved by things such as social support, and perhaps improving the information within the network, perhaps tailoring the information to the individual as well as the physical availability. So it's not just a question of plonking a computer in front of people. If people can't use the internet because it's a bit too complicated, or they haven't got a physical ability to use a mouse, and that's where maybe a kiosk would be particularly useful. We need to think about presenting information in the right way. Clearly, one of the things that many studies have shown is that main sources of information remain health professionals. The balance here may change. We may get to use computers more often, but still, at the moment, health professionals are the main source of information for most. Another big source of information is other people, mainly families and friends, and of course, lastly, the internet, leaflets, TV, newspaper, radio. The internet's not the only source of information. So I don't know if in America you have this expression about different ways to skin a cat, but there are different ways to try and improve equity, improve the accessibility of information, and improve equity. You might think about, for example, making sure that a person's support network has good access to the internet, supporting the support network. This may be another way of ensuring access to information. One of the points that comes from that is that it may be that printing may be important in some situations. Although, of course, I know I've also had a lot of comments in over the last few weeks from people who said that kiosks where they've got printers which aren't looked after properly can be jammed with paper and not used well. On the other hand, maybe the issue there is about the keywords are not looked after properly. We'll come back to that later. Anyway, physical access is obviously not just as simple as providing a kiosk. You've got to provide a kiosk which can be used. So this is the NHS Choices website at the moment. I know that Mark Lambert is in the chat room there. So if, for example, we wanted to give better access to this website, we couldn't just put this on a kiosk without redesign. You have to design your pages properly and make them suitable for kiosks. So, for example, you might have a very simple design, such as this, and I'm going to show you what it might look like with maybe a talking head along the top. So you can think about kiosks where you've got the talking head and the person asks you a question and you say, can you answer yes, no, wrong way, yes or no, and that could be also, of course, in different languages. So puedes decirlo en español y luego tú puedes contestar en verde para sí y en rojo para no. Or in Urdu or whatever other language it might be. And one of the things that we can do with kiosks, and we should be thinking about doing with kiosks, is if we're developing these for people who aren't very good at handling a mouse, aren't very good at navigating the internet, we need to design kiosks appropriately. And we might think about taking kiosk feeds from some sites. I'm sure that many of you, at least in the UK, will know the excellent site called Dipex, which is a database of patients' experiences. And one could imagine a kiosk version of Dipex where you take the various examples of patients talking about their, in this case, diabetes or other illnesses, other conditions, and having that on a kiosk with a changing front end, different people coming up on the kiosk each time you look at it, to encourage people to use it. So it needs to be big and it needs to be easy to navigate. One of the things we found, I'm going to ask you in a minute about your views about the use of kiosks with handsets. We did some work back in 1996 in Scotland where we videotaped a lot of people using a kiosk over several months, and then looked at whether we could actually define what was an episode of use for those users. and one of the things we found that was you had to have a very fast timeout, so that people would time out, the next person would start again from the beginning, and if there was a constant stream of people using a kiosk, you wouldn't know when one person ended, the next person began. So we thought that a good idea was to have kiosks with a handset, because most people, when they're using a handset, will hang it up, so be there. This will mark the start and end of an episode. Or it's also, of course, a way of controlling sound, so that people can listen to a multimedia presentation, audio, video, without the sound being broadcast to everybody in the neighbourhood. Interesting that not that many kiosks seem to have a handset, or when they do, it's always thought of as being for use by to contact somebody at the other end. But I think kiosks with handsets are quite useful for containing sounds. I'll be interested in your views later on. So I said at the beginning I wanted in a way to define kiosks into two groups, and these are those two groups: opportunistic kiosks, which might be cited in the community, which are mainly looking at health, education or promotion, the sorts of things that many of you will be aware of with the NHS kiosk when it came out, Health Point a long time ago, Health Chips, the Michigan kiosk in the States, and then those kiosks which are integrated with services, registration to a clinic, as we saw with the person coming into the health centre in Texas, the patient interview kiosk, and the collection of data, maybe some sort of feedback about what's going on in the clinic, or maybe education, where you refer a patient to go and use a kiosk after seeing the health professional, or before seeing the health professional, maybe some sort of information prescription. So clearly I think the kiosks in these two situations are probably different. It may well be that the first one there, the integrated use, can be a bit more sober looking. You have a fairly relatively dedicated job, maybe for registration or for patient interviewing if you're sitting down, whereas the health promotion kiosk might need to be much more attractive and get people to come and use it. I'm going to go on now to think about how we should evaluate kiosks, because clearly whether kiosks have a role or not is whether you judge them as being successful. So you need to think, well, how are we going to judge whether they're successful? And the way of judging their success, of course, would depend very much on the aim of that particular kiosk. So is it an opportunistic kiosk trying to promote health? Is it a kiosk integrated into a clinic for a particular patient group, education? Or is it a kiosk for patient interviews? And we can't really give an overall plan for all those kiosks. We need to consider each one separately. And if we're considering, for example, the health promotion, the opportunistic kiosk, where maybe we're trying to change behaviour, we do need to consider, well, what are the alternatives? And I put this slide up really because there are other ways of doing things, and kiosks aren't necessarily the answer. They may be something which complement other ways of approaching health promotion. We all know the anti-smoking campaigns, the reduction of drinking campaigns, and this is an interesting example of getting a health topic into a soap opera. I'm not sure if soap opera is the word they use in the States and elsewhere. In Spanish it's telenovela. You get this into the sort of a program on TV where we saw somebody die of cervical cancer, and immediately got in the weeks that followed, the months that followed, we got a 21% increase in the number of smears. So that would obviously be a fairly low cost intervention, perhaps compared to a kiosk. Kiosks there may be more tailored to the individual, and that's what Matthew Crota and others did in the study called Reflections of You kiosk in St. Louis in the States. They had 4 kiosks cited between 2003-2004, noting in passing that the use of the kiosk average use was about 5 to 6 minutes. And what this kiosk did was to produce an 8-page tailored magazine. It took a little while for the printing to come out, but it's interesting to note that they did have printing. So maybe somebody was looking after the printers. They cited these kiosks in 40 different places: 8 beauty salons, 8 churches, 10 health centres, 6 laundrettes in our language, 8 social service agencies. And they found that the laundromats were the best places, and they were used 10 times a day. So here we have a kiosk used 10 times a day. How would we evaluate it? Well, they noted that 1 in 3 of the people using it had never had a mammogram, and that the users in the laundromats had the worst knowledge scores, the lowest screening rates, the worst indicators of deprivation. And in the laundromats there were 10 uses per day. So how would we evaluate that? Well, you might sort of put a notional cost for the kiosk and take it from there. So let's assume that those kiosks cost £3,000 a year. That's fairly high cost. You maybe I'll do it for cheaper than that. That's about £10 a day, $20 a day. So 7 women who had and 3 women who had not had a mammogram completed an interaction and produced a magazine using that kiosk. Although Matthew Crota didn't do this cost-benefit analysis, this is my own attempt looking at his own study. We don't know about behaviour change, but was it worth £10 a day? I would think, personally, I think it was. Other kiosks might not be worth quite so much. Another way of looking at this is in consumer health information. Not all kiosks aim to change behaviour. Some might just be providing health information in the same way that a health authority, a hospital, a health board might provide leaflets. So can we value that information provision? Well, in a study back in 1996 we asked people what they thought the use of this kiosk, HealthPoint, was worth to them, and they averaged 20p, and with 60 usages per day, which interestingly in that situation was 116 users, because most people were being used in pairs. The capital cost of £4,000 was paid for in a year, so again that seemed to be cost beneficial. On the other hand, the NHS kiosks, I did an evaluation study of this in 2001, 136 kiosks, and we found that most kiosks were only used 49 times a day, and a fifth of them were used less than 4 times a day. And clearly in that situation, if a kiosk's only being used 4 times a day, is very unlikely to be cost beneficial. And in fact the NHS kiosks were withdrawn a couple of years ago. I think there was problems in getting the right sites for them. So it is a question of getting the right sites, the right look to the kiosk, getting the right content, and we can learn from much that's happened before. And we need to think about how and why do people use opportunistic stand-up kiosks. Well, first of all, they don't use them for long because they can't stand too long. They use them for about 2 minutes. Generally speaking, they're browsing, they're not searching. They're likely to use them again if they think something is new, so it needs a simple interface, it needs shallow navigation, and it needs to catch people's interest and be obvious, and change the content frequently. If you can tailor the information, that is, make the needle in the haystack a bit bigger and easier to find, as Matthew Crota attempted to do in his kiosk, that again will help to keep people's interest. So let's just go back a minute to equity of access and think again about whether or not kiosks have a role to play in trying to improve equity of access to the internet. Well, we've been talking about health promotion kiosks, and there are a whole variety of programs now on the internet, education of particular groups, or maybe therapy for particular groups, taking for example cognitive behavioural therapy for anxiety and depression. So if we wanted to make this available to all those people who don't have access to the internet, yes, we could think about using a kiosk, but it's not quite the same thing as just plonking a kiosk in the street somewhere and saying, well, let people search for health information. You need to find the right site for these specific health education or computer-based therapy. So it might be in a booth, this lady sitting down with headphones on, using a multimedia package for management of anxiety. We know that there are websites such as this one, Living Life to the Full. This is a free website available to anybody, which helps cognitive behavioural therapy for depression. At the moment, you couldn't just put this onto a kiosk as it was. We'd need to negotiate it with the authors of Living Life to the Full to see if we can develop a kiosk version to make it available to those people who don't have access to the internet. So how and where could we make such resources available and refer people to use them? Well, we might think about referring people to the public library, because in the UK, at least, I don't know what the situation's like in the States or Holland or Iceland, but in the UK at least, most public libraries do have internet access, and you can get assistance to use the internet. So we could refer people to use the internet as it stands in libraries. But you could also think about having kiosk-based services in based in health services, in health centres, where the same information is represented in a simpler format using a kiosk. And certainly in the study that we did back in 1998, we recruited 71% of the patients who were referred to a public library to go and use this computer and to take part in the study were recruited. And given that we were actually asking them to take part in the study as well, the public library seems like not a bad place to include with all the other places where we might give people access to information. And certainly libraries in the UK are being used for self-help, for referral to self-help book schemes. Paul Farrand is a colleague of mine in Plymouth, and he's published a paper about this self-help book prescription scheme. So I'd be quite interested in views from other countries, the US, Holland, Iceland, and anywhere else who may be logged in today. What you think about the siting of kiosks and booths in other non-health service locations. Let's now look at another paper looking at the evaluation of kiosks. This is a study of mine from 1999. It wasn't a kiosk as such, it was a booth, so people were sitting down using a touchscreen computer, and certainly in this case we were able to do a randomised trial, and it's encouraging to see that a number of the papers in recent years have been randomised trials of booths and kiosks and different ways of using computers, direct use of computers by patients. So we looked at compared tailored information versus general information versus best possible provision of leaflets. Interestingly, we found that this is you won't be able to see it in detail, but it was a bit like a website. So the yellow words were hot words. You touch on them, but obviously bigger font than you can use on the internet, than you would normally use on the internet. Interestingly, our study showed that full access to the booklets actually was more expensive than providing a computer system with printouts, and the tailored system was even better, but the hospital in which we did the study didn't implement it because they said they had no money to actually carry on with the research. And that's one of the problems that we see in many studies that aren't continued. It's not that they're not cost effective, it's just that the health centres and the hospitals that you're working with don't give them the priority that sometimes that they deserve. So we need to show perhaps cost savings as well. So what are some of the necessary conditions for successful kiosk use? Well, certainly I think you've got to have personnel with the motivation to look after it. As I said, I had a number of comments back from users where they said that they got a kiosk in their hospital, but it was broken down, or the printer's jammed and no one's looking after it. Well, I don't necessarily blame the suppliers of those kiosks for that. I blame the people who bought the kiosk in the first place, because if you're going to buy a kiosk and use it, you want to use it effectively, so someone's got to look after it. Obviously though, if it does cost too much to look after, or there's too much effort involved in looking after it, then it doesn't become cost effective. There's some obvious things about kiosks that are so obvious they shouldn't really need stating, but perhaps they do. The design and location have got to meet the goals. You've got to know what the goal is, so people buying the kiosk need to be able to give you what is the goal of this kiosk. There are issues to do with privacy versus publicity. Way back in 1992-93 we did studies where we found that a kiosk in a library, for example, needs to have more privacy than a kiosk in a supermarket. In a supermarket, people don't really care about being seen, and in fact we had kiosks in pubs, bars, where people would gather around the kiosk and use them as a bit of a joke. If a kiosk's in a health service setting as a registration kiosk, it doesn't need as much privacy. As long as people can't see the screen, people won't mind being seen using the kiosk because everybody's using the kiosk. So there's not a simple answer to this. It depends very much on the particular kiosk. Obviously you don't want kiosks that the printers jam, or the kiosk doesn't look right for the particular audience. If it's an opportunistic kiosk, it's got to grab people's attention, and people have got to know that it's health. Maybe it's a bit of fun to go and use. If it's an integrated kiosk, it can look more sober, and it can look part of the furniture because everyone's going to use it. And clearly, if you've got people proposing to use a kiosk, they need to learn from the experience of others. And in preparing this webcast, I've got a database now of 229 references, numerous publications, and I will mention Dave Nicholas and colleagues who were responsible for quite a lot of them. They produced a book and did this whole series of studies between 2000 and 2004. I don't know if Dave or others are logged on today, but I'm sure they can give you examples of their studies. But there are numerous literature, and I'm hoping to try and publish this as a review later on, so people might want to get a copy of that. Necessary conditions number 2 is that there must be management commitment to using a kiosk. We're in March, which in Britain is the end of the financial year. It's a typical time that a hospital might say, oh, we've got 2,000, 3,000, 4,000 quid left over, let's buy a kiosk with it and stick it in the waiting room. It's not going to work, because there needs to be management commitment to use it properly. Kiosks aren't just furniture, they're not just wallpaper. You have to have a clear idea, explicitly stated goals, so that you can measure the success. And the numbers of certain types of users is obviously the simplest type, and you could at the very least work out the cost per use. If you know that a kiosk is being used 60 times a day and it's costing £10 a day, you've immediately got some idea of the cost per use, and then you can decide whether the value is worth 60p a day. It may result in effective processes, it may result in better patient flows. So the people buying the kiosk need to know how they're going to evaluate it. And secondly, we need to get better progression from research to service to avoid the sorts of problems that I reported with my own studies, where even though the research showed it was worth it, it was cost effective, we didn't get it implemented as service thereafter. So, do I think there's a role for health kiosks in 2008? Well, as a replica for the internet for information seekers, no. Putting kiosks in the street to give people internet access, I don't think is going to work. But if you integrate it with services, maybe registration, maybe patient interviewing, maybe the collection of data, education, or some sort of information prescription, yes. And if you want to have it as some sort of novel and entertaining way of supplementing mass media health promotion through tailored messages, again, yes, I think health kiosks have a role. So, your views and discussion. I'm going to take a short break now, and I'm going to read any questions and comments that may have been made while I've been talking. In the meantime, do continue the discussion amongst yourselves. What I do is I suggest that you break into 2 groups by going to rooms R1 and R2, and you can always switch again between those rooms or back into main. So I'm going to remind you how to do that, the breakout. If you're in main, to go to another room, R1 or R2, type room R1. So that's /room space R1, then press enter. And similarly for R2, or if you want to come back to main, do the same again. And I hope that, as I said, I'm just introducing this topic. There are many people in the audience today who've got vast amounts of experience in, for example, patient interviewing, various educational uses of computers, I'm not sure who exactly they are. I need to turn around and have a look at my computer in a minute to see who's logged in. But do share your experiences with others. Go to R1 if you want to talk mainly about opportunistic kiosks. Go to R2 if you want to talk mainly about integrated kiosks. Stay in main if you're not sure what you want to do, or flip between those different rooms. And I'm going to leave that up and turn the sound off, and I will come back in this window a bit later on to sum up. But in the meantime, hope you enjoy the discussion. Okay guys, so I'm going to take advantage of the fact that I've got the video window and you haven't. I'm going to pick up on some of the things there. I'm going to find it easier to just go back through the video window. Somebody asked about the relationship. I think it was Lawrence asked about the relationship between internet versus kiosks. I think that a lot of internet sites should think about having kiosk feeds. That is, as the example I gave, I think really with Dipex, it's an excellent website. Why can't Dipex maybe provide a kiosk feed such that you take a much simpler presentation of the same information in a kiosk-friendly format, one where the opening menu would change so that people would get a different cut, a different slice through the information day by day. There's been discussion on, I think it was room 1, about translated versions of websites, and I think this is where certainly a multimedia kiosk where you use that I messed around. I was the wrong way around now, but I messed around sort of showing you could have somebody talking and you could have the buttons underneath it, so you can get around not just language but literacy as well. So you could have kiosks where, for example, in the patient interviewing circumstance, the person could ask the question verbally, and they know that the green button is yes and the red button is no. Or in terms of information, the same sort of thing. You can present information using a lot more audio and video for people who've got low literacy as well as people who don't speak English. The paper I put up of, I think it's Ernest Hunter from Australia. In that case, the indigenous population have been responsible for producing a lot of the information within the kiosk, and not only has it's mainly in English, but it's presented in a way which is culturally sensitive to that group. When I was in Glasgow, we got school kids to come and research topics and produce them, and then they were interested in the kiosk and they brought their parents back to look at the kiosk. They couldn't spell, of course, but that's another story. Somebody's asked about how to get Department of Health funding if the beneficiary is the local provider. That's the same problem as you got for any health intervention. I think talk to the likes of Mike Kelly from NICE, and from the public health point of view. We shouldn't let these sort of barriers stop us. I know that they do, but we shouldn't. But the kiosks is no particularly different from any of the others there. Mark, you asked about differences between, I presume you were asking about the publications. I didn't quite get the context of the question, but I presume you're asking about the publications and where you've got the use of a kiosk for a specific topic: cancer information, patient interviewing, the breast screening one from Kruta, for example, versus the more general kiosk. Yeah, I think it's undoubtedly it's easier to get money from a research point of view to do that type of study. Partly that's one of the sort of reasons why I went from the more general work with kiosks to specific studies. It's easy to do an RCT for a cancer booth where you've got a particular health outcome, such as knowledge about cancer or well-being or quality of life or anxiety and depression, and you can do an RCT kiosk versus leaflet versus something else. If you've got a more general kiosk which is providing a whole range of different topics, it's quite difficult to evaluate it, because you can't really evaluate it in terms of behaviour change or knowledge or health outcome, and therefore I think you have to take the consumer information approach and say, well, what would I be doing if I wasn't doing this? I'd be having to give the people leaflets, and therefore this should come out of the leaflet budget. Can I at least work out how much it costs per use? Is that worth it in terms of the alternative way of providing health information? But I think on the whole it's a mistake to try and make a kiosk reproduce the internet. You can't possibly do the internet on a kiosk. You can only do so much of it. Obviously you can branch and focus down on what people are trying to get information about, but trying to represent the internet on a kiosk is a mistake. I think you should maybe have kiosks which maybe one day they're focusing on cancer because that's the outpatient clinic which is using that area. The next day it might be diabetes because you've got a different clinic. You can use kiosks, different things, different times, but remember that stand-up kiosks are only used for 2 or 3 minutes. A booth in a health service setting might be used for 30-40 minutes. You're not going to have people there for long, so you need to remember that. Laura asked whether kiosks could be used for doing the nice guidelines in patient-friendly ways. Well, clearly they could. It's a question of whether people are going to read them. So I think there'd be no point having a kiosk for nice guidelines. If you've got nice guidelines about child health and you put it in a child health clinic as part of something else, then maybe people will want to read it. Gordon talked about the printer problems can be solved by device monitoring going back through the internet. I mean, I agree, but it just seemed to be one of the comments that came back to me from various people. Maybe that wasn't working properly. I'm going to turn the sound off now, go back into the chat and come back in here in a minute. Hi, I'm going to come back in. Donald Nicholson, who's from Leeds, asked about the ease of use and might it not put people off from older people and people from disadvantaged areas. I mean, I think that there is still a gradient in kiosk use, but it's so much less than, for example, internet. And I cited one paper, which I think was from Cornwall actually, that where they showed that older people were quite capable of this. I'm sure if Alan Wenner's in there, he's got older people and people from all sorts of backgrounds using their computer interviewing software. I think that most of the literature and the experience shows that if you design it well, a kiosk will reduce the barriers to accessibility that would be there perhaps well, certainly there in internet use. Way back in 1993, we did a study of Health Point in Glasgow. We put them in Clyde Bank, which was a very working class area, shipbuilding area in Glasgow, and they were used by 17% of the population, and the gradient of use between the under 50s and the over 50s was 20% under 50, 13% over 50. We had people over 80, 90 using the kiosks. If they're simple and they're easy to use, I think it is a way of bringing in older people and a way of bringing in people who aren't used to the technology of the internet, and particularly following on from the conversation that's been going on about other languages. I think it is also a way of bringing in people with other languages, because maybe if you put a kiosk in a certain area of a certain town, and there's quite a lot of the kiosk papers publications from the States have been to do with having it in English and Spanish, and in the UK it might be in Urdu or whatever other language. In Plymouth it might be in Chinese. So whereas putting all that information on the internet and in other formats might be more difficult. And one of the things I think is that you can also get involvement from local communities in terms of producing the information themselves, so they can take part ownership of that kiosk. You can get volunteers to come in and present the information so that their community group has access to the information. I mean, yeah, sure, there's still a bit of a barrier, but it's much less than with other formats. Back to the chat room. Hi, me again. Just pick up on a few things. First of all, just to remind you that there's actually 3 chat rooms with conversations going on, main, R1 and R2. So if you seem to have exhausted one in the room you're in, you might like to go to one of the other rooms to see what's happening there by doing this. The instructions which will be up there again in a minute, /room space then R1, R2 or main. Notice that some people I think it was Laura was talking to Chris Dawson or somebody from WellPoint. WellPoint is one of the commercial companies which are in the chat room there. I mean, I don't think anybody from In Touch with Health is there. Some of you may have come across that system. Start Here is another provider of kiosks, more than just health. Alan Wenner is from Instant Medical History. I'm not sure if that's the correct term for the actual company, but that's the product from the States, patient interviewing. So there are a variety of companies around. What I would like to see is for the merging of these systems. What's tended to happen in the past in the UK at least is that we tended to think of kiosks as being things that you plonk in community areas for opportunistic uses, but actually kiosks can be used in all sorts of areas. And I think, as Alan said in one of his comments, there's a whole range of things here. We need just to think about what the actual health, the outcomes we're looking for, whether we're trying to change behaviour, meet information need, collect information. Quite often, if we can collect information, we can tailor information to the individual. So we should be thinking about the patient workstation. Way back when I produced a paper called Researching the Patient Workstation, we seem to be not getting there very quickly, and it'd be nice if we could get there quicker. Donald asked about the issue about involving local groups, and yes, it's a good point that if you do involve local groups, you then got the problem about whether the information you're providing on a kiosk, opportunistic kiosk, is evidence based or not. But I think you can build some sort of process in Donald that where you agree that it's presented in the terms that people want it presented, but you do some sort of quality check before it actually goes out. Of course, in terms of the internet, that's where we're getting into a whole new range of whole new area, such as through chat rooms such as this, but maybe for particular topics. And what's the role of the health professional in terms of chat rooms? And we've got quite an interesting project going at the moment where we're going to get health professionals to take part in chat room discussions about self-harm. But that's another topic. Back to the chat room. Some people may find too much going on in the chat room a bit distracting from the video window, so perhaps keep it to a minimum. But if you want to type a question now or during the process of my presentation, please do so, and I'll come back to it at the end. Currently you're in the main chat room. If you look just above my head there, you'll see a thing saying you are in main. Later on we're going to be able to go to another room, room R1 or R2, and you can do that by typing /room space R1. Make sure that you don't have a space between the slash and the room. You do have a space between the room and the R1, and then press enter, and that will take you off to another room. If you want to come back to room main, you type /room main, back to room R2 /room space R2, and so on. So you'll be able to move between the 3 different rooms, main, R1 and R2, as the proceedings of the discussion go on. And later on we're going to divide the comments between the points of clarification to me, or if you can't decide quite where else to put it in main, and we're going to put discussion about opportunistic kiosks in room R1 and discussion about integrated kiosks in room R2, and I'll describe what I mean by those 2 definitions of opportunistic and integrated a bit later on. But we're going to try and separate the discussion. Email that you will see there, you can always email Innocencio offline, Cito, as he is in the chat room. I think it's now 3 o'clock. I'm going to start. do health kiosks have a role in 2008? So as I said, my name's Ray Jones. I'm from the University of Plymouth, where I'm Professor of Health Informatics. Before that I was at University of Glasgow. I'm the Master of Ceremonies today, so I'm going to give you my views on health kiosks, but then hopefully we'll hear a lot more from you, because there are a lot of people there in the chat room I know who've had extensive experience of the use of kiosks in various ways, in various modes. So this isn't just about sort of my views, it's everybody's views. So what are we going to talk about? First of all, that's the technical problems. If you have any problems, contact Innocencio, Sita Maramba, and try and keep the chat room for discussion. In case you sort of haven't worked it out, you've got the user list there on the right hand side, you've got the webcast window, and down the bottom you've got the input area for your chat. And please do feel free to type questions or comments as I go through. Obviously I can't answer them when I'm looking at you here in the video window, and I will review the chat room dialogue at the end of the presentation and then respond by this video window, that system, and they have several in their waiting room. So it's not just about information giving, it's also about information interviewing, or as in the case here, this is a report from the Picker Institute, and it's looking at patient feedback. So here you've got the computer on a stick idea, where you might get feedback at the end of a session to try and find out about outcomes. As I said, this is an example of a booth where the person's sitting down to use it, and these basic simple ideas about whether someone's standing or whether they're sitting down or where it's sited are actually very important in getting the computer to be used in the way that you want it to be used. That particular picture's from a study we did in Glasgow. This is, as I said, the self-assessment idea, where you can get your weight, height and so on, and I'm sure that many of you will have seen this type of application of a kiosk. And of course increasingly we'll get teleconsultations. This is from the Guardian, from a system installed in Aberdeen. I'm not sure if we have anybody from north of the border logged in today, but this is from the Scottish Centre for Telehealth, and another type of kiosk. So when I've been talking about opportunistic health kiosks, really what I mean are these a little bit to make it a bit more manageable. I'm taking a very broad view of the idea of kiosk. Basically I'm talking about any publicly available touchscreen patient-computer interaction. The Dalek thing on the left there isn't actually a health computer, it's a police touchscreen kiosk in Glasgow. The others are more traditional looking Dalek type computer, one from Wellpoint with a blood pressure monitor, and on the right hand side you'll see a booth being used in a library, and down below it the man on the wheelchair using different types of interaction altogether, so in a museum display. So clearly computers can be used for a whole variety of things, such as registration to a clinic or welcoming to the clinic. The left-hand picture there is from some health centre in Texas. The bottom right-hand picture is from Camberwell Sexual Health Centre, and I've taken from the web. Computers can be used, touchscreens can be used for patient interviewing, and as I said, Alan Wenner is in the chat room there, and he says that electronic medical record system providers now include interviewing software part of the software. So over 50 of the EMR providers in the States include patient interviewing, and John Backman, who's from the Mayo Clinic, certainly uses that. Well, hi, I'm Ray Jones, and I'm going to start in a minute. I'll give chance for some of the people just to log on a second. One point I will make is that the chat room is going to be quite crowded today. Later on I shall tell you how to change rooms. We've got 3 rooms there for the breakout discussion, and I'll give you those instructions in a minute. I will make the point that when we do get into discussion, because there's quite a few people there, make sure that you preface your remarks by in response to what Alan said or what Lawrence has said, or I agree or disagree with someone's name. Otherwise the chat may get a bit disjointed. But we will also be dividing up into 3 groups. I'm just going to get my PowerPoint back to the right place, and then in a minute we will start. Hopefully you can all hear me. If you have problems with sound, don't please try and put too much in or anything else to do with the presentation. Try and have that solve your problems outside of the chat room, perhaps with Innocencio Maramba, who's